The content herein is for informational purposes only, not intended as medical advice, diagnosis, or treatment, and is not to be substituted for direct advice from your doctor.
Welcome to Lymphcast, the gathering place for physicians, healthcare experts, and special guests. We dive into the world of lymphedema, venous disease, and other related disorders, exploring their impact on your daily life. So settle in, unwind, and join us as we uncover everything you need to know about lymphedema and related conditions on our engaging show Lymphcast.
Today's Lymphcast episode is proudly sponsored by Tactile Medical.
Greetings and welcome to our Lymphcast show, episode 31 tonight. We're glad you're with us. And we want to let you know tonight's show is being sponsored by Tactile Medical, a leader in home lymphedema solutions. Tactile Medical healing right at home. We also want to direct you to our podcast page, and you can find us pretty much anywhere. But if you go to the lymphcastnetwork.com, everything is there. But we're also found on Apple Podcasts, Spotify, TuneIn, Stitcher, Amazon. We are all over the place. Take your favorite podcast platform, type in Lymphcast Podcast, and you'll find this show. And of course, we're on YouTube as well. If you'd like to see us, you can do that. On listening only, we're available everywhere. So let's go ahead and meet our panel tonight from New York, RVT, Jacqueline Sasek. Hello, Jacqueline. How are you?
Well, I'm well, thank you. How are you?
Not bad. We were commenting on the background you have there. That looks great. Did you paint that yourself?
No, not that talented.
Okay. From California, our regular panel member, Dr. Emily Eicher. Hello, Dr. Eicher. How are you?
Thank you. All is well. Thank you. Finally, I figured out which Zoom I have to click on. And I thank you so much for inviting me, and greeting to all of you.
Okay, glad you're here. And the founder, owner of Vita Support MD, also the founder of this show, this Lymphcast show. And his company, Vita Support MD, makes Vein Formula 1000, Lymphatic Formula 1000, from New Jersey physician and surgeon, Dr. Johnny Chubak. Hello, Dr. Chubak. How are you, sir?
Hi, Paul. I'm doing fine. Very excited about today's show. Thank you very much.
Yeah, you bet. We are ready to go. In fact, why don't I just hand it right back to you and you bring our special guest in, and then we'll take off from there.
Okay, great. Well, as you all know, and I say over and over, one of the things that I love so much about being one of the hosts of the Lymphcast podcast is how much I learn each and every time we have one of these programs. I do consider myself an educator and someone with great expertise in this area, having practiced cardiovascular surgery for 22 years and specializing for 15 years in venous and lymphatic disorders. But that being said, I'm always learning something. And as I introduce today's guest, I know that I'm going to be learning. And for that reason, since I have not met Mary Calys personally before, I am going to read from her abbreviated bio, because there are things in this bio, as I was looking over it in preparation for today's show, that I know are new to me and may very well be new to some of our listeners and even some of our co-hosts. So Mary Calys is a physical therapist with over 22 years of experience as a clinician and a consultant in a wide variety of settings. She's worked in outpatient, acute care, home health, and private practice. And over these years, she's developed a passion for treating and managing lymphedema. She also has done cancer rehabilitation, complex geriatric, and she's worked with chronic pain populations. All I can tell you personally from experience, very challenging and rewarding patient populations to work with. In addition to holding her physical therapy license, she's also a certified lymphedema therapist, CLT, and had her training through the Norton School of Lymphatic Training, which we've talked a lot about on this program. And hopefully one day we'll have a representative from the Norton School on the program to hear about their training program. Mary also holds certifications that include, and this is the area that I was referring to in my introduction, that I feel like I have quite a bit to learn. Mary holds additional certifications that include cancer exercise specialist. I think something that Jacqueline might be very interested in, and Dr. Eicher as a physical medicine rehabilitation specialist. She's a cancer exercise specialist, and she got that training at the Rocky Mountain Cancer Rehabilitation Institute. She also has expertise in functional dry needling, and she's a functioning dry needling functional dry needling specialist through Kineticore, and therapeutic pain specialist through Evidence in Motion and Purdue University. She currently serves as a senior clinical specialist at Tactile Medical. As Paul mentioned, Tactile Medical is the sponsor of today's program, and we thank them for their support, a great company. Her position provides ongoing clinical education and training to healthcare providers and patients in chronic edema, cancer survivorship, and pain management. So with that amazing introduction, I want to welcome Mary Calys to the program. Thank you, Mary, for being with us today.
Thank you for having me.
It's a pleasure. Well, with that introduction right off the bat, I would open the floor to either Dr. Eicher or to Jacqueline if they might have any questions for Mary to get the conversation flowing. There's so many directions we can certainly go, it seems.
First of all, thank you, Mary, for being with us. And with your vast experience, it's amazing that you still look like a high school kid. So keep on going. You have many years ahead of you. What is functional dry needling specialist?
Functional dry needling are thin monofilament needles, like an acupuncture needle. It is a mechanical treatment. There's no cannula in the needle, and we use dry needling for a variety of reasons, both orthopedically, but I also started using them with my oncology patients for a variety of reasons. So you can stimulate blood flow, you can reduce pain, you can numb pain, you can block nerve pathways that prevent pain signals from traveling to the brain. You can improve muscle function, you can decrease muscle tone, you can relax fibrotic tissue. And if you apply it with electrical stimulation, that can cause a gentle contraction and relaxation of the tissues, which is similar to the concept of MLD. Sometimes I will set up a whole channel of needling in a neuronal pathway and connect it to the electrical stimulation to treat things like chemotherapy-induced peripheral neuropathy. But I can also help reduce the pain and the tingling, numbness that can sometimes be associated with lymphedema.
So do you insert needle?
I do.
How deep do you go?
Depends where the target tissue is. If it is something fairly superficial that I could be tapping on bone, then I know where I am, right, in the body. If I'm going somewhere like quadratus lumborum, I need to know my tissues and where all my vessels are, and I need to know exactly where I am and how deep I could go. So the needles could be as deep as long as 5 inches, or they could be, you know, 1.5 inches. They could be very microscopic if you're using them in the fingers.
Yeah. With all honesty, I never knew anything about functional dry needling specialty. The only thing is, when we talk about it, that's wonderful that you can apply it. What is the pathophysiology, the mechanism of this?
Definitely, it induces a trauma to the tissue, which brings in more blood flow, helps remove toxins from the area. Initially, people who did dry needling were using a trigger point model. That is really not the model that I learned by. I learned more of a Western style of medicine, where we look at innervation of the muscles. So I may not be able to needle in a specific place because of injury, tumor, or something, but I can stay in that neuronal pathway and implement a change by inserting the needles and applying E-stem.
But we all know in lymphedema, first of all, lymphedema is painful, and in subcutaneous tissue, you can reach lymphangiones, and you can lymph collectors, and aren't you injuring them by dry needling?
I did not have that experience, Dr. Eicher. That, you know, when I did my training, I specifically asked about treating patients with lymphedema, and those, if there is an injury to a vessel, it is a temporary injury.
I see. Is there any literature, you know, as a lymphedema patient, I would be hesitant for anyone sticking a needle into my leg.
And I probably wouldn't use it that way, honestly. The way that I really apply dry needling is, say that I have a patient who is a breast patient who has a lot of fibrosis and a lack of mobility with their pectoralis muscles. I can insert the needle there and apply E-stem, and I can get lengthening of that tissue and return of range of motion within one treatment.
Is there any study done on this?
Yes.
Relating to lymphedema and the outcome?
Yes, there are. And I can provide those after this.
Why don't you post it, because I would like to learn about that.
Sure.
And I would be hesitant to injure a patient with just simple lymphedema. Another thing is when you have scar tissue and in introducing a needle like the acupuncture into the scar tissue, but to go to a lymphedema per se, to fairly congested tissue consistency, especially if you talk about lymphedema of lower extremities and distally, I think, is this superior to manual lymph drainage?
It's different. It would not be used in the same way as manual lymph drainage. So, when you think about an oncology patient, many of them experience something very much like PTSD. And they assume a posture where they are very elevated in their shoulders and they are not breathing properly. And a lot of times I can relax their upper traps. So I may not be targeting where you see the lymphedema, but when you think of the person as a whole system, a whole person, there are places that, anything I can do to calm the nervous system will help with that lymphedema diagnosis as well. And that would be more how I would use it versus using it solely. Although there are studies for lymphedema, I typically do not use it that way. I do it more for calming of the nervous system, relaxation of tight muscles that are more likely it is a neuronal response to trauma. And in those instances, the needles are very effective. Now, there are some patients that just aren't candidates for functional dry needling.
I see.
They may have a needle phobia, and then I would not select that for them. But it's, this is not something I would use on everybody, but it has been very useful in many cases.
Well, I think that this is such an interesting conversation. And, as I said, this is why we have these programs to share our knowledge and discuss new ideas and expose ourselves to new things. And it's funny that not funny, but ironic that Dr. Eicher picked up on that, because I had interest in it also. And I would say this, as a surgeon with many years of surgical training as a board certified general surgeon and cardiovascular surgeon, I have to tell you that over the years, my perspective on this kind of subject has changed quite radically. What do I mean by that? I agree with Dr. Eicher's concern about needling, traumatizing tissue in a patient with lymphedema. Now, that being said, I've had this discussion many times, and I've discussed it with a lot of very knowledgeable people. When I was a surgical resident, general surgical resident, it was really dogmatic that if you had a patient, for example, with a lymphadematous upper extremity after breast cancer and axillary node dissection, that arm, whether it was lymphadematous or not at that point, but it had a compromised lymphatic system after axillary lymph node dissection or biopsy, we were trained dogmatically, like a religion, that you don't take a blood pressure in that arm, you don't start an IV in that arm, you don't give an injection in that arm. That arm is a compromised arm and should never be traumatized, and certainly not penetrated. And I had no reason not to believe it. I was taught that, and I believed that. So fast forward many years from, let's say, the beginning of my general surgical training through cardiac surgical training. And I did a lot of oncology surgery in my training and breast rotation at Memorial Sloan Kettering and so on and so forth. And I carried that belief system with me as law. Now, if you fast forward into my career as a venous specialist and doing, for again, more than 15 years, vein procedures for people with venous insufficiency, chronic venous disease, phlebolymphodema, etc., I came to a point which was very much a sort of anxiety-provoking moment where I started to see patients with significant lymphedema and venous insufficiency, with clear great saphenous, axial insufficiency, wide open reflux, swollen limb, lymphedema, sometimes in the face of primary lymphedema and I had two sisters like this recently who are going to be on the show. Two sisters who carried the diagnosis of primary lymphedema from adolescence, and now they're in their 50s, and both had severe venous insufficiency. So now the conundrum becomes what to do. I know that I can quote unquote fix that vein by performing an ablation procedure with a laser or ultrasound guided foam sclerotherapy, etc. Well, to be quite frank, early on in my career, I was terrified in those situations to do harm. And it was easier for me to say, listen, I don't think you're a candidate for any kind of invasive procedure where we're going to breach the skin, injure the vein, burn tissue, potentially injure more lymphatics, et cetera, et cetera. And eventually, slowly but surely, as my career progressed, and I saw more and more of these people suffering, and I got more opinions from experienced people and so forth early on in my experience. Eventually, I had a long talk with the patient and family and consent forms and discussion that there's always a small chance that we could make things worse by performing an endovenous ablation in this circumstance or whatever. And long story, a little less long, I eventually began treating those patients with intervention. And lo and behold, touch wood, I have never had a patient, not only who got worse, but I've never had a patient who didn't get better. And so that came as a huge surprise to me. And I was, as I say, really, I was concerned. I mean, I don't think it's inappropriate to say that I was terrified the first time I did that to a patient, because here I was under the belief that if you put just a simple IV in a patient's vein, you could potentially develop a massively swollen limb and so forth, debilitating situation. And now here I was putting an endovenous laser fiber inside the vein and ablating it with high temperature and so forth, causing quite a bit of trauma to the surrounding tissue and so forth. And as I said, touch wood, it has always served the patient very well, and we haven't had any problems. But so to both of your points, I can see where Dr. Eicher is coming from to think she would be apprehensive, and I get it, because I was apprehensive, because I was doing far more than placing a fine needle in the skin. But to my pleasant surprise, in appropriately selected patients, I have always found that intervention, which is quite invasive in terms of especially a thermal ablation, we've found tremendous results in those patients with lymphedema and phlebolymphodema when they have significant venous insufficiency, and that decreased venous hypertension in the leg and the unloading of all of that excess fluid that the lymphatic system has to deal with appears in those situations, in my experience at least, to be more important than any additional micro trauma that you might be doing to the lymphatics. So it's a very, very interesting discussion. I want to go to another question, which would be, I think, the basic question. I mean, the most fundamental question for somebody like yourself, Mary. What led you to this career and interest in lymphedema?
It started way back when my first exposure to lymphedema, although I didn't know what it was when I was a child, and a close family friend had breast cancer. She had a radical mastectomy. She developed a huge lymphedema arm, and it became so devastating that they amputated her arm. I was about 10 when that happened, and wow. I was really left an impact on me. Many years later, my father, who had had a clot when I was a young teenager, went on to develop chronic venous insufficiency, had multiple wounds, and he had been admitted to the hospital for IV antibiotics, and 48 hours later, that bag of antibiotics had not been hung. And just the lack of appropriate timely care frustrated me so much that I decided I was going to go get trained and I was going to treat him myself. And then finally, I started a cancer rehab clinic, and I was treating lots of patients, and I was referring to lymphedema therapists, but they were so their caseloads were so heavy that we needed so many more lymphedema therapists to really treat the population that I became certified so that I could do a better job with them and get them treatment sooner. So I've been kind of led down this road for a long time and just rather fascinated by it. And I think it's a very rewarding area when you can really help people who have suffered for years. Or if you can prevent that suffering at all, I think it's fantastic.
Yeah, I couldn't agree more. Very interesting. I'd be surprised if you didn't, but do you know Cam Ayala?
No.
Okay. Cam Ayala has been a guest on our show, knows Dr. Eicher very, very well. Wonderful young man who, unfortunately, not too dissimilarly to your family friend who lost her arm, he lost his leg. He's a beautiful young person, and he lost his leg. In fact, he was kind of a bit of a TV star. He was, I believe, on The Bachelor and things like that. Mm-hmm. And he had lymphedema, as I recall, was primary lymphedema, which he kind of neglected, to his own admission as a young person, and didn't wear his compression to the degree that he should, and developed several bouts of recurrent cellulitis. And Dr. Ike and I did a telephone consultation with a wonderful young woman from Texas today, who has had sort of a similar history of repeated bouts of cellulitis, some which were life-threatening, in fact, in her case.
Right.
People have to understand she had bacteremia on several occasions and was admitted to an ICU and really was in a septic situation. So lymphedema can be very severe. In Cam's case, it led to a septic joint, finally, and numerous procedures to try to eradicate the infection in that septic joint. And eventually someone elected to try, kind of in a radical, I guess, hopeful kind of attempt, a knee replacement, which then became infected. And ultimately he wound up with an above knee amputation, which was really quite a tragic outcome. Fortunately, he's still alive and he's well, and we're very grateful for all of that, of course. But it points out, A, how serious lymphedema can be, and B, what I love so much about your story is how so many times when we meet medical professionals, we hear personal stories, how something that happened to them personally led to a career path. And you had these experiences with your father and with the family friend and so forth. And of course, Dr. Eicher, she was obviously interested in medicine and was in a surgical residency prior to having lymphoma and developing lymphedema, which changed her trajectory so much. So personal stories are always so important in our path in life in general, but in healthcare, it's no different. Anybody else want to ask any questions of Mary, or any comments?
Mary, so I do have a question. You spoke a little bit about treating the patient, the whole patient. So like coming from a systems perspective, I love that. Can you talk a little bit more about what techniques or therapies that you use to treat the whole patient?
Sure. Well, to me, I was a social worker first, so I definitely think in terms of the whole person, and cancer survivorship really appealed to me because it does treat the whole person. It not only looks at the diagnosis, the impacted structures of the body, the limitations in function, how it affects people participating in society, how does their environment play a role, what comorbidities would play a role. All of that really interests me because I do not think that you can treat a patient just by looking at their lymphedema. You have to see how that fits in the context of every role that they need to play in life and every function that they want to fulfill. And so that strategy really appeals to me. The reason that, I initially started out treating the symptom of cancer-related fatigue, and I was doing that through exercise, various types of exercise, following the literature on that. then it became apparent, okay, a lot of these patients are swollen. I need to learn how to treat that. So I learned how to treat that. A lot of these patients have old orthopedic concerns. Maybe I could use my dry needling to treat that. And then I became certified in pain neuroscience, because a lot of what I see, we see nociceptive pain. We may see peripheral neurogenic pain that becomes more of a centralized pain syndrome. What kind of interventions can I do for that? So I went and got training to really treat those types of pain through pain neuroscience. My training is really training patients through metaphors. It's not through anatomical lessons. It's teaching them metaphors to reprogram how they think about pain and how they respond to it. So, some of the treatments that go along with that would be treating sleep hygiene, nutrition, doing graded motor imagery, doing relaxation and meditation, breathing, stretching, all those things that we know that really help people become more well in general. But I have found that even with patients who have metastatic pain, that pain neuroscience, just teaching them how to reprocess their pain is very effective.
That's fascinating. It's funny because, as I said, Dr. Eicher and I were on a Zoom call consultation with this young woman, 46-year-old woman from Texas. And I want to give a shout out to my dear friend, Dr. Dave Batra. Dave's down in Dallas at the Texas Vascular Institute. And he came to know this woman and advised her to reach out to me and to Dr. Eicher for a consultation and discussion of her lymphedema that she's been dealing with for 24 years. So Dave, Dr. Batra, I want to thank you for that and for thinking of us. Anybody in the Dallas area should look up Dr. Batra if they're in need of vein care. But one of the things that Dr. Eicher was very, very emphatic about with that patient today, which I thought was wonderful, was stretching and breathing. Isn't that true, Emily? Didn't you talk to her about that today?
And you had very valid point, Dr. Chubak, when you already met before our Mary had a discussion. We have so many variety of techniques, but not everything is applicable to everybody. You have
Correct.
to assess who is the patient, what are the basic needs of the deficiency, and then address that globally, because it's not, even with lymph, it's not one size fits all. And we have to look at one global, wholesome human being with some problem, and then accordingly select from the repertoire of modalities that we have and address those modalities that are perhaps most efficient for this patient. And our patient, not only we recommend a complete manual lymph drainage and all this therapeutic exercises as we do in our setup here in Santa Monica in Lymphedema Center, but we combine nutrition, we combine breathing exercises, and we combine all the stretching and so on. But this was something very new to me, to do the dry needling. I was trained by I'd like to say His Majesty Professor Leduc, one of the founders of the European group of and world group of lymphology. And in the old days, we were specifically instructed never to have any needles to put in, as you, Dr. John, mentioned already, and be very careful with any kind of cuts and opening and so on. And this is some new modality that you are introducing to the world of lymphology. Fascinating, and I'd like to see some studies and compare the studies to myofascial and all other techniques. But again, right, it may not be applicable for everybody. It may be applicable to someone that you perhaps with your expertise assess that patient will benefit from that and not to be harmed. So that's very, very interesting point. And yes, I would love to see some literature and some statistical analysis to see the benefits, especially for the lymphedema patient. And you mentioned your early experience that there was amputation of the upper extremity lymphedema. In the old days, and I am a little bit older than the high school studies that happened here, and in the old days, 20, 30 years ago, we used to see huge upper extremity lymphedema. Now, with the advance of sentinel node biopsy, we see maybe stage 1 lymphedema of upper extremity and not stage 2 and stage 3 and so on. So we don't see as involvement, but we see different types of lymphedema. I see now a lot of prostate cancer with residual lymphedema after surgery and so on. So things are changing. And now we know that we have lymphatics in the brain. In the old days, we were taught, no, lymphatics doesn't reach up there. So it is fascinating to see the progression improvement. And a few days from now, I'll be heading to Genoa to the ISL meeting, International Congress of Lymphology. I'm eager to learn something more, something new, and advance and use that for our patients. And again, we have to see who is for what modality is applicable for certain patients, not perhaps for the other people.
When I always say that you really have to identify early on, you have to build rapport and identify early on what is it that motivates that patient. And a lot of times what's the strongest motivating factor is how they want to participate in society. So I think of a patient as an entire system. And I think if I can break into that system by maybe making a goal for societal participation, if I can make some advancement there, then it's almost like a domino effect that happens. If I can work on different areas of what makes the whole, but I try to identify where I need to go first. And that's where I begin. So sometimes it's something as simple as I want to be able to hold my grandchild. I want to be able to walk my dog. It's usually something very personal and meaningful. And if I can make improvement in that, then I can usually gain their trust and get their buy-in to do all the many things we ask them to do with complete decongestive therapy, which is not a simple plan for life. It requires some dedication and commitment.
Agreed. We talk again and again on this program, and it goes back to Jacqueline's question, which was a wonderful question, that this is a comprehensive treatment plan. As we said to the patient earlier today, we don't have a cure for this problem or this group of problems, chronic venous insufficiency, lymphedema of any cause, etc. But we do have great treatment and we do have great management. And that management tends to be multimodal with hands-on therapy, compression, in some cases surgery. Again, you want to talk about a radical idea and sort of a heresy to when I was training, which again, I'm not in high school either anymore. The idea, when I first heard the idea that anybody was doing liposuction on people with lymphedema or lipedema, I couldn't believe it. I mean, we came from, we're not going to put an IV in this patient's arm. We're not going to take a blood pressure on this patient's arm to, I'm going to do liposuction on the subcutaneous tissue of this patient. I mean, I couldn't believe anybody could even conceive of the idea or attempt it. And now we're seeing more and more this is happening. To this point, Dr. Eicher, you can correct me if I'm wrong. I don't think we've had any of those surgeons on our program, but I can't wait to talk to them. I have never done those procedures. I know they're being done successfully in the right hands, and again, in the right group of patients. But Dr. Eicher, wouldn't you agree that, and when you talk about lymphatics in the brain, she says in the old days, those old days weren't that long ago. This idea of lymphatics in the brain is only a few years, from my understanding, that it's been accepted. But wouldn't you have thought 20 years ago liposuction for lymphedema or even lipedema was a radical concept?
Well, as you remember, in our medical studies, how much did we learn about lymphatic system? And in my surgical, 0 and maybe 1%. And in my surgical rotation, what we were instructed to do a fast saphenous vein ligation for coronary artery bypass graft. How much did we pay attention to the lymphatic vessels right next to the saphenous vein? No. And it was wonderful that the patient ended up with great heart. And then how much did we pay attention to the inflammatory process going on in that leg? Not that much.
Zero. We would tell the patient, quite frankly, don't worry about your swollen leg. You're lucky to be alive. You had heart disease.
Exactly.
You know what I mean? So, and I'm a heart surgeon, so I went through all that training, and I saw my older professors have those discussions. But Emily, I can tell you on that same track of thinking, when I was a surgical resident, especially going in peripheral vascular, I had some attendings that were really fantastic technical surgeons, and they were so proud of how, when they did a groin dissection, let's say for a femoral popliteal bypass, they completely dissected like an anatomical textbook, the artery and the vein, and everything was exposed, and every lymphatic tissue was excised and thrown in the garbage with the electrocautery, and everything was skeletonized, and it looks so beautiful. And now when I think about it, at the time I didn't think twice about it. Now I'm horrified. What's also incredible, and again, when you talk about we always want more studies, we always want more science, we always want more evidence, it is inconceivable to me how many of those patients who had massive groin lymphadenectomy just for exposure of the vessels because it was a beautiful dissection and so forth, that never developed a swollen leg. I can't explain how those patients didn't all develop a massively swollen limb, but the vast majority of them did not. And as far as I can recall, almost none really developed a massively swollen limb. So there's more going on in some of these circumstances than we always kind of initially believe. And as we learn more, we're going to understand more. But I had an old professor in neurosurgery, Dr. Lustgarten, John Lustgarten, brilliant guy, trained in Yale and Columbia and so forth. He always used to joke, his big line was, I'm not sure we understand everything we know about this. So it takes some time to develop the real understanding of these issues. And that's why science and papers and studies and good studies, double-blinded controlled studies, prospective studies, this is what we're always looking for on this program. And but that multimodality approach, exercise, diet, nutrition, supplementation, surgery when indicated, interventions when indicated, hands-on therapy, again, graduated compression, how much, even again, let's talk about a subject that's very highly accepted now and how things have changed. Well, one is bed rest. Again, I'm not 100 years old yet, but I can remember being a general surgical residency after stripping procedures, and the treatment was bed rest. These people with big venous stripping, because it decreases bleeding and so forth. Today, you would be considered completely ignorant if you advised the patient bed rest after these vein procedures. But we did. So we learned and we changed. But the other aspect that I was going to mention, now it slipped my mind perhaps about how things have changed. But anyhow, it's a multimodality treatment. I know what it was. As I told you, when I was a surgical resident, and Dr. Eicher remembers this very well, we were warned you never put a blood pressure cuff on a patient after lymphadenectomy. But now everyone is using sequential compression devices on these lymphedematous legs. My concern when I first saw those devices is how much pressure is enough? How much pressure is good? How much pressure is damaging? How much? I prescribe lymphatic compression, sequential compression, pneumatic compression on patients all the time. And I've seen very good results. But again, when I first saw that come out, I thought it was very, very counterintuitive to what I had been taught about even taking a simple blood pressure on a limb. So we are learning all the time. And the thing that we need to do is we need to question what we think we know. There's a great old expression that says, it's not what you don't know that hurts you. It's what you know that ain't so that hurts you. So we all have these belief systems that we grew up with and we want to hang on to, but we need to challenge our own knowledge and our thoughts and be open to new ideas, because in the 20 years that I'm in practice, when it comes to venous and lymphatic medicine, it's unrecognizable, the change that's taken place.
For decades, lymphedema was a silent disease. Few in the medical world understood how to treat it. Patients felt lost, unheard, with nowhere to turn. As a community of providers, therapists, caregivers, patients, and lawmakers working together, we're changing all that. And we all have a part to play, providing greater access to treatment, stopping the progression of the disease, and empowering patients to maintain the life-changing benefits of treatment. We know it's the simple things that change lives, the things most people take for granted, like the ability to swallow, wear a wedding ring, or put on their favorite shoes. The everyday joys, that's what matters, and you are making them possible again. Today, because of you, lymphedema is being recognized, treated, and managed. A community working together, making everyday joys possible again.
Let me segue into another question, which I think is an important one, since today our sponsor is Tactile Medical. Mary, can you talk to us a little bit about your role at Tactile Medical specifically and what kind of work they do for our listeners?
Sure. I am part of the clinical services team, and our role is to provide education. I actually provide education in the central region of the United States, and I have 3 counterparts. And we speak to physician groups, nursing groups, therapists, teaching them about various types of lymphedema and how to utilize intermittent pneumatic compression as an adjunct to complete decongestive therapy, that it definitely has a role. What a lot of people don't know is that it is recommended by the NCCN to use pneumatic compression as an adjunct, as well as in the venous world. There's also an expert consensus that recommends the use of intermittent pneumatic compression. So in my own, I do teach about that, answer questions like we're doing today. Today I'm in Oklahoma City making clinic visits with some of our reps, meeting different therapists and physicians, and just seeing, learning what their thought process is and when do they believe in intermittent pneumatic compression, what kind of strategies do they like to use, and we discuss that. And I think it's very helpful and beneficial. And I think really the goal is to spread the word that there are a number of ways to go about treating lymphedema. Not everybody has the benefit of going to a manual lymph drainage to a CLT. They may not have that in their area. They may not get referred or even recognized to be sent to a CLT. So I think that it's very important that we are out there increasing knowledge. I mean, I can't tell you how many people I've met that they've had lymphedema all their life and had no idea what it was. I think it's very important that we continue that education.
Well, to all my team, as I mentioned, I will be in Genoa at the meeting. My dear friend, Dr. Jean-Paul Delgado, invented a pump with indocyanide green in it. And
really? Huh.
And I am eager to see and perhaps try it in me. And I would respectfully ask him to join our podcast so he can tell us more about this specific pump treatment, which then demonstrate how the lymph vessel progresses with the indocyanide green filling in as we are pumping. And that's something new, and I hope that he's going to have a workshop there. So I will be happy to introduce him to us so we can see the more advances in terms of compression treatment.
That's fascinating. I can't even imagine. I'm trying to envision what you're even talking about, to be quite honest, and I how that pump and the indocyanide green work together. It's a fascinating thing. That raises another subject. I had a professor one time who never ordered a lymphoscintigraphy because of the injury from the needle. They thought that itself could trigger a massive lymphodematous response. So many interesting questions. I have another question for Mary and for Dr. Eicher, because I'm sure you're both up on this. What can you tell us about the recent developments in, and you'll forgive me if I'm misnaming it, but I believe it's called the Lymphedema Treatment Act that recently passed.
Yes. And it has been a long time in the making. It's one of the frustrations as a lymphedema therapist that I've had for many years is you treat somebody, you reduce their limb, you make their range of motion better, you make them feel better, and then insurance does not cover the cost of their compression garments. And that is really the role of the Lymphedema Treatment Act, is to get insurance coverage for gradient compression garments. And I believe that part of what they have recommended is that each patient gets 2 sets of garments every 6 months with an overnight garment every year. And then they can get replacements if they're needed, but there's still work to be done. CMS asked for comments. I think yesterday was the last day they were accepting comments. So I think there's more to come on finalizing that Treatment Act and how it's going to work. It's supposed to be in effect in January 2024. So we will see if an agreement can be reached on all the issues and that actually happens.
We just hope that it will be approved, because a lot of patients cannot afford to pay for the compression stockings or sleeves or hand gloves and so on, and they are very expensive.
Right. And it does include custom garments as well as off the shelf. So it would be a major win for patients with lymphedema.
It sounds like it would be fantastic, but I always tend to be a little bit skeptical, only because I had a couple of reps from various compression garment manufacturers visit me in the office recently, and their concern, of course, is the old trick that we sometimes have played on us, which is, okay, this garment is, let's say, a $70 retail garment, and the government says, yes, we'll reimburse for it. Here's $10.
Right.
So if we wind in that kind of situation, it can be a disaster too.
That I believe when we do the manual lymph drainage protocol, including the pump, I think according to Medicare, they pay $16.65 for a pump treat in the office setting. So, the cost of the pump, of course, very, very challenging. So I hope that it will improve in the future. And we are happy that we have some improvement overall. But what I want to point out before we break, that most of the therapists, if not all, they are highly dedicated, educated therapists, and they are pouring their hearts out to all these lymphedema patients. It is not, perhaps dialysis or so, where you stick a needle and watch the patient. You are constant in touch with the patient. You assess what is the best modality for this patient. So the therapist, and I compliment you, Mary, that you are so educated, and from a little personal story, you are now this giant and teaching a lot of therapists and everybody, and you are so great with all your patients. So congratulations for that, and don't stop, continue and carry on.
Right.
Well, Paul, I want to just echo that. And I want to include Dr. Eicher in that. I have to tell you, as a surgeon, how impressed I am with people, my colleagues, who have dedicated their careers and their lives to the treatment of people with lymphedema, and the challenges that go into that care, because it's very, very labor intensive. It's physically intensive for the caregiver. As Dr. Eicher has pointed out, reimbursement can be a real challenge when one is trying to run a practice and take care of their massive overhead and take care of their employees in a proper way and pay staff appropriately for the good care that they provide to their patients and so on and so forth. And it really is a labor of love, in my opinion. My observation has been those people who have dedicated their career to this, it's quite sacrificial. I have to tell you, there's a great amount of sacrifice that goes into it. And as one of my old professors, Dr. Jeff Hicks at the University of Rochester used to say, the practice of medicine is a noble one, but it can be a burden. And it's a burden worth carrying, but it is a burden nonetheless. And these people like Mary Calys, like Dr. Emily Eicher, and others that we've had on our program, Dr. Mark Moline, who's been with us in the past and so forth, who's an incredible wound care surgeon, they have really made tremendous sacrifice in their life to take care of these people with chronic, incurable, debilitating diseases. And as a surgeon, I feel blessed because I feel that I'm in many more situations where I can have more lasting kinds of results and immediate response to care that patients can find very rewarding and so forth. And I just have the most, the utmost respect for people like Mary Calys and for Dr. Emily Eicher because of the work that they've been doing and trying so many different ways to help these people. I want to mention again Dr. Eicher's website, lymphedemacenter.com. You'll be lucky if you can get her, because I know that we were talking about having the young woman we talked with today go out and see her, and it's at least a couple of months in advance now. So if you do feel that you need her expert advice, opinion, or therapy, please don't hesitate to call, because it may take a while to get an appointment with her. I think as we come to the end of the program, before Paul signs off, I would give Mary the last word and ask her if she has anything at all that she wants to share about herself, her story, Tactile Medical, etc.
Well, I think we've hit on it. I really think the value of what we do as clinicians is we work with the patients side by side in the trenches with them to really help them find a better quality of life, to try and try and try and try until we find something that works. And I think that's the reason I came to Tactile is because it gives me an ability to reach more people, to have a bigger voice, to really help impact change in this population and really help patients learn and find solutions to problems. And I hope that came through today.
Absolutely. Very, very much so. I think it's been a great program. And, Dr. Eicher mentioned that she's off to Genoa in Italy for a very important conference. She'll be meeting our other co-host, Dr. Monica Glavitsky there, and also a former guest, Dr. Peter Glavitsky, who's a brilliant surgeon, was a professor at Mayo Clinic, chief of the vascular section for many years. They'll all be connecting in Genoa. And the reason I mention it is, again, very much in harmony with the idea behind today's program. Why are they all going to Genoa? They're going to teach, but they're going to learn, and they're going to share ideas, and they're going to find out what's new, and they're going to put their heads together and see, is there a better way? Because we don't have yet the right way of treating lymphedema, venous insufficiency, lipedema. We don't have the right way of treating cancer, of all the various types of cancers, coronary artery disease, et cetera, et cetera. Medicine is never done. We're not complete. It's a work in progress. And the reason that our esteemed colleagues who take this profession so seriously do meet and convene on a regular basis around the world is for that one purpose, to keep learning and growing and sharing ideas and helping one another to make healthcare and medicine more and more complete and more effective. So I thank you for that, Emily, and I thank you, Mary, for being on the show. Paul, back to you for our sign-off, please.
All right. If you don't mind, if I could just make one comment. Is that okay, John? We have a minute?
No.
We don't have a minute?
I'm only joking. Of course, Paul.
In that case, I'll take 3 hours because I can do that too.
Yes, of course.
Well, you mentioned people in the medical field. All the panel tonight, you referenced Dr. Moline and Dr. Glavitsky as well, going way above and beyond essentially the call of duty to do as much as they do for patients. But to me, as the outside medical guy, not only do I see that, but whatever you did for that particular patient perhaps another therapist or physician down the road will call you and say, hey, I have this patient who has whatever. And you can say, well, you won't believe this. I did this 2 years ago when I went above and beyond the call of duty. And they tried and it works. And now you've helped 2 patients. And I'm guessing that just tends to snowball and continue over and over. You're not just helping the one patient. You might be helping 50, 100, 1,000. Who knows, right?
Absolutely. And that's the idea of the Lymphcast broadcast. I mean, the podcast is all about that. It's about sharing what we know. As we say at the beginning of every program in our disclaimer, which we mean very seriously, we're not giving medical advice here. We're discussing ideas. We want every patient who has a problem to go see their primary care doctor, their specialist, and ask questions. We're not looking for disciples on the program. We're looking for students. We're looking for people who want to know more about their condition. And for our practitioners who are listening, doctors, therapists, nurses, physical therapists, certified lymphatic therapists, on and on and on and on. We want them to be asking more questions and sharing with us what they know and asking us questions. Paul, would you mention again the website where they can send their questions if they want us to discuss anything on the show?
Yeah, and I'll do that at the very end of the show as well. But if you have questions, send them to the following email address. We'll put it in the show notes as well. hello@lymphcastnetwork.com. That's hello@lymphcastnetwork.com. And that's how they can reach us, John.
Right. Well, thanks very much. And keep spreading the word. Tell your friends about the program. You know, the response has been fantastic. It's a labor of love for us to come on these programs, mostly at the end of the day, after a long day in treating patients and so forth. And Dr. Eicher, being on the West Coast, breaks up her day in the middle of her clinic and so forth. So we do make a great effort to make this program accessible to the public, and it's all for the patients ultimately. And we hope they'll tell their friends, their doctors, and anybody who might be interested in the subject matter so that we can just make it better and better as time goes by.
All right. Very good. You've been listening to and or watching a Lymphcast episode 31 tonight. We thank you for being with us. And before we give you the final information, how to find us, in case you want to pass that along, let's go ahead and thank the panel. From New York, RVT, Jacqueline Sasek. Thank you, Jacqueline, for everything.
Paul, and thank you, Mary. It was a pleasure. Thank you.
Oh, you bet. Great job as always. From California, Dr. Emily Eicher. Thank you, Dr. Eicher, for everything.
Thank you, Mary, the whole team.
All right. And okay. And Dr. Chubak, before I officially thank you, would you take a moment to once again thank our special guest?
Well, thanks very much, Mary Calys, physical therapist from Tactile Medical, for all the good work that you do, the knowledge that you share, the education of other healthcare practitioners, and keep up the good work. We hope to see you again back on our program. We hope to meet you in person at some of the conferences and seminars that we all attend. We'll be in Miami at the American Venous and Lymphatic Society and
be there.
The UIP meeting. And I look forward to meeting you and spending some time with you personally at that time. Dr. Eicher will be coming off of a plane from Genoa right to Miami for another conference. She's a world traveler, a jet setter, as are the Glovitskys. So we all hope to meet there. And Emily, safe travels. And Mary, thank you once again. Jackie, thank you for being here. And look forward to the next one, Paul.
All right. And of course, the founder of this show, also the founder, owner of Vital Support MD. They make Vein Formula 1000. They also make Lymphatic Formula 1000. Physician surgeon from New Jersey, Dr. John A. Chubak. Thank you, Dr. Chubak, for everything.
Always a pleasure. Thank you.
You bet. And again, Lymphcast episode 31 tonight. Check out our website, lymphcastnetwork.com. And remember the email address. It's on there as well. If you have a question, send it in and one of our panel will answer it. hello@lymphcastnetwork.com. And the podcast world, we are everywhere. Apple Podcasts, TuneIn, Stitcher, Spotify, Amazon, name it. Type it in and you'll find us pretty easily. Also on YouTube. Again, it's been Lymphcast episode 31. Have a great night and thank you.